We have time for discussion. Can I have the other speakers up on stage, please?
I would like to address a question. Last year in the corresponding meeting, Amato showed us impressively that the airways play a major role why we need higher peak levels and reduced tidal volumes, because the collapse of the airways during the expiration that takes place every breath by breath is not reopened when we use a low tidal volume. This means that we need automatically perhaps higher peak levels when we reduce tidal volumes, and I was quite impressed from the stress index data that finally the optimum PEEP is somewhere about 16. And my direct question now to Dr. Brouwer is why the NIH subsequent trial is using recruitment maneuvers, I believe, around 35 centimeters of water, when Americans, like in the Azeta trial, are using peak inspiratory pressures up to 100 centimeters of water, and why are they still using so low PEEP levels, and what is the perspective of the upcoming NIH trial in this respect?
Well, I think a good response to that is a very long one, but there are several questions and related thoughts to that. First, with respect to why are we doing recruitment maneuvers with 35 centimeters of water? Actually, the trial that we're doing is not using recruitment maneuvers now. We're just using higher PEEP, as I showed on one of the earlier slides. We did, in the same context of this study, a set of recruitment maneuver experiments with 35 centimeters of water, because we're trying to learn more about whether recruitment maneuvers, first at these more conservative levels of pressure and duration, are going to be safe, and whether they'll give us some encouraging improvements in arterial oxygenation. So we're being very conservative in this respect. I'm not sure that I can say anything more that's going to be satisfying to those who have bought into the idea that doing these measures, whether they be recruitment maneuvers or higher PEEP, are definitely going to give a better outcome measured in terms of mortality. As I said earlier, I think it's easy to build a strong case, and I buy it, that measures such as this can confer lung protection. But what needs to be demonstrated is that we get better outcomes measured in terms of what our patients are interested in.
Thank you.
Patrick Honzig from Switzerland. To use these techniques, you have to use muscle relaxants. At the same time, we try to avoid muscle relaxants as much as possible because they have their own side effects. Are there any techniques recommended to apply in patients without relaxation?
Very good question. You want to get that, Marco, then maybe Laurent?
That's a very good and very important question. And unfortunately, all the data that we have presented, and I think the same is true for you, Laurent, were obtained during sedation and respiratory muscle paralysis. What we are currently doing, and this is actually a multi-center, not randomized trial, trying to implement the use of the volume pressure curve measurement at the bedside, and we want to know if we can obtain those measurements just with sedation without respiratory muscle paralysis. And we are trying to implement this, this method, and we'll see. In the near future, we may have some more consistent information.
Laurent, do you want to add anything, or any of the other speakers? Can I ask you either, well, let's say Marco, the stress index concept, which is a very nice one on a breath-by-breath basis. What are the pitfalls of using the stress index? You know, for example, patients with stiff chest wall, how will that affect the stress index? And what are any other pitfalls you want to discuss?
Well, the issue of the chest wall mechanics, I think, is crucial in the context of understanding all these processes, and I think Luciano may have a better view of all this, this problem. Related to the assessment of the stress index, actually this is a very recent observation that Salvatore did, which is my old partner but never-ending partner. I don't want him to commit a suicide later on. He observed that actually the shape of the curve, including the chest wall or without the chest wall, is always the same. So even in the presence of patients with compromised chest wall mechanics, the shape of the pressure time curve of the respiratory system is similar to the shape of the pressure time curve of the lung. I'm not saying the absolute values of pressure are completely different, but the shape of the curve during the constant flow inflation looks like similar. So we may still use the stress index approach.
Luciano?
Well, Marco, don't you think that is a little bit too early to sell out the stress index approach? Because we had 3 slides on the future and maybe one abstract in the SON and some ex vivo experiment. But it seems to me that the basis of the reasoning, when you are in whatever straight part, okay, you think to avoid down and up, but you may have, as an example, an opening which is proportional or a closing which is proportional to pressure, and you have a perfect straight line, and you may have also stress. I mean, do you think we need maybe a little word of caution? Because I appreciate the enthusiasm, but
Absolutely.
you know, I wouldn't like that everybody get home, look at the shape, put the PIP at 20, and maybe dangerous or not.
Absolutely not. And I can see you're getting a little bit old, Luciano, because a few years ago you would have the same enthusiasm that I had. But actually, it's that's why we are running all those studies, because we need those answers. But going to your physiological question, I don't think we still have enough data to support clearly one concept related to stress index. That is, even if you get the straight line, that doesn't mean that the lung is fully recruited. And I perfectly agree with you. But the stress index measurement, unless based on our measurements, again, on a dead piece of meat and in a first series of 15 patients, is telling us if you get a straight line and then you do a recruiting maneuver and you open your collapsed alveoli, you see the change in the shape right away. And try it.
No, my question, I don't want to spend all the time. My question is just that you may have whatever perfect straight line in whatever condition, if you have a recruitment and de-recruitment which is proportional to applied pressure. For a given, I don't say you have to recruit everything, but I inflate 3 alveoli, then +1, then I inflate +1 according to the pressure, you come out with a straight line. So I think that basically I found the concept fascinating and intriguing, but I think we will face sooner or later in some number of patients the same problem that we had when trying to design the ventilation over the volume pressure curve, because this is an application in dynamic condition of the volume pressure curve straight line concept.
I think that the imaging data that are required to verify
imaging data will be essential to understand.
Yeah, I agree with you, Luciano. Clearly, it's early days.
Thank you.
But, not completely. But I think that the strategy that Marco's talking about, where you go to higher volumes and you try to recruit more, and then you go back and you see, it gets at that to some extent, because you can see the same thing in the animals as well. You see a nice straight curve. Doesn't mean for sure it's recruited, but if you do go to higher volumes, do recruitment, at least you have a higher probability. Still not 100% guaranteed. One last question. We have, we're basically at the end of time. I actually had some slides to show. I'm not going to show those. I think the discussion is more important. Can we have a microphone here? Luciano, I couldn't help but ask you, Roy and I think Laurent, and Marco all said that we have to wait until the randomized control trials are done before being able to tell whether this approach is useful. What do you think of that?
Well, I mean, if we have to wait a randomized trial for everything we do, I think we will not invent even the wheel at the moment. I mean, we do not even know if to use PEEP has not been checked in a normal trial. I mean, some common sense and applied physiology when big trials are not available. This is a rare condition. To collect 700 patients, you need billions of dollars, and you test one hypothesis over the 300 interactions that you may have. So I think it's very difficult to pretend to have a clinical trial for everything. Once one strategy has been very well designed on a physiological basis and proven in a small trial before maybe the widest application, maybe it's worth to do it. But not just one little maneuver, let's see, now I want to know if 7 is better or worse than 6. So I have to wait 3 years to do what? I mean, we have to look in a more maybe complete way. No? What I would like to compare are the strategies instead that one given maneuver or just the movement of one knob on the respirator.
Roy?
Well, as physicians, we're in an interesting position where we don't have to wait for a study that proves that a wheel, as you coined it, is truly round. You can go to your ICU now and use a higher PEEP and any technique that you feel you're capable of. But I think physicians have seen things that they thought were wheels, and they turned out not to be wheels many times in the past. And you know, the best example that comes quickly to mind is the use of lidocaine as prophylactic treatment in myocardial infarctions, or flecainide to prevent PVCs and runs of ventricular tachycardia. A lot of clinicians bought that idea. It turned out not to be a good idea once more information was gained. So I think for the time being, until we have proof that this wheel is truly round, we as individuals have to customize our ventilator approaches and do the best we can with individual patients, thinking about everybody, every fact that we can find at the bedside. But we should always be insecure in relation to the notion that using higher PEEP is better until we have proof of it.
Luciano, you wanted to say another word? Press your button. Press the button.
Just 2-second comment. I think it's very difficult for everybody of us, when you are at the bedside, to distinguish between the cure of the lung and the cure of the gas exchange. Usually we tend to cure the gas exchange, which is not sometimes a very wise thing to do. And in this way, I think I perfectly agree with Brower. If we can cure the lung with a better gas exchange, I'd be more happy. It's the cost that we pay for everything we do.
Exactly.
Nothing ideal exists.
I think that's the big point, and the difficult thing for physicians to do at the bedside. How do you weigh the advantages and disadvantages? Which really we have a feel for weighting what's worse and what's better, but we really don't know. We really don't know in many cases. Last question from the audience.
Yes, this is a question for Dr. Ranieri concerning the stress index. As I understood, you modify the shape of the pressure time curve by adjusting the PEEP level. I was wondering, did you have the chance to study the shape of this curve after a full recruitment maneuver and see how this shape modifies, and if this has an impact on the PEEP level you finally need to apply to have a coefficient of 1?
It does, it definitely does. In fact, as part of the protocol, we evaluate the shape of the curve to set the ventilator after recruiting maneuver. Because what we have seen several times, that you go up with PEEP, you fix the tidal volume to the 6 ml from the NIH data. You go up with the PEEP, you get a straight line. Then you do a recruiting maneuver, and the stress index becomes lower than 1, because you have opened some new units that are somehow seen by the ventilator, while before were not seen by the ventilator, so they were causing the downward concavity. And then you increase again the PEEP level, and finally you get a straight line. Then you repeat the recruiting maneuver, and when the lines remain straight, then by protocol we decided to stop. But again, it's just, I mean, don't go back and do it. I mean, if you want, but it's just something we are trying to establish right now.
Yes, but after a successful recruitment maneuver, the only thing can happen if you change PEEP is that you keep on over-distending the lung.
If the lung, that's why we need to know how do we wean the patient off of this protocol. Of course, if the pathological process is over, that breathing pattern, few hours later, will cause overdistension. But the interesting approach is that you can see it on a breath-by-breath basis. And sometimes, from hour to hour, you can see how the situation is changing. One specific breathing pattern on the ventilator on hour 3 is getting you to a straight line. On hour 6 is getting you to overdistension. An hypothesis could be then you decrease the PEEP level until 10 centimeters of water pressure, and then you are off, because if you can keep a patient with a low PEEP level and a reasonable low FiO2, then the aqueous part of distress syndrome is over. But again, they are just hypotheses.
Yeah.
See you in a couple of years.
I think that, you know, generally with the recruitment maneuver, actually B goes up when on subsequent breaths. I think we should stop now. So let me thank the speakers for you for excellent talks and discussion, and thank you very much to Siemens for making this possible.